Hi, everyone. My name is Marcella Pomeranz. I'm a nurse practitioner for a large GI practice in Las Vegas called Digestive Associates. I've been practicing for over 8 years. I'm our lead nurse practitioner, so I'm in charge of 12 other APPs, and I have a passion for education and teaching, and I've really enjoyed my role as lead. So I'm excited to talk to you today about some important things to consider when we're managing patients with alcohol and MASLD. So the first thing I want to address is how I effectively screen for patients with alcohol and how to get them to be honest about their consumption, right? Because we know that a lot of people lie on their AUDIT-C paperwork. So we want to just be open-ended with our patients, let them know that we're there for them. We're really here to assess their risk, monitor their progression over time, and ultimately try to get them to be as healthy as they are able to be and willing to be. So I do use the AUDIT-C as a way to kind of gauge the severity of alcohol consumption. So I'll ask them, do you drink weekly or monthly? And when they answer that, I'll ask them, when you do drink, how much do you drink? For males, I'll ask them, how often are you drinking more than 6 at a time? Or for females or anyone over 65, I'll ask how many times they're drinking more than 4 drinks at a time. And you can kind of gauge if a patient's being honest with you, right? So if you feel that they're being a little bit vague or they're hesitant to admit exactly how much they consume, just reiterate that you're here for them, right? And I think that does help promote an open relationship because we're going to be watching these patients chronically over time. We also use PEth levels as a baseline to monitor progression. So phosphatidylethanol is a serology that we can use, which measures a byproduct of alcohol consumption that gets accumulated in red blood cells and allows us to detect if alcohol has been consumed in the last 2 to 4 weeks. So if you get your history and they're really still being vague or you're not sure, you can always throw on a PEth and use that to basically track their progression over time. So how do I explain to patients the deleterious effects of our metabolic dysfunction and our alcohol? So the detrimental effects of alcohol combined with metabolic dysfunction is due to synergistic mechanisms, right? It accelerates liver injury. It also promotes fibrosis and adverse outcomes. So even low to moderate alcohol can amplify steatosis and fibrosis progression. And to me, there really is no safe threshold, right? So I want to encourage complete cessation as much as possible. So the alcohol and the metabolic dysfunction basically acts super additively. So it increases oxidative stress and lipid peroxidation. It also promotes inflammatory cascades, which can promote progression, right? So we start with steatosis, then we're getting steatohepatitis, now fibrosis, advanced fibrosis, ultimately getting into cirrhosis and hepatocellular carcinoma risk. So we want to reduce our risk factors as much as possible. And alcohol consumption is definitely a big part of that because it promotes the synergistic effect of injury. We also know that alcohol impairs our mitochondrial function, which can disrupt lipid metabolism, also increasing gut permeability, which can further aggravate hepatic inflammation and fibrogenesis in the setting of other metabolic disorders like hypertension, hyperlipidemia, and diabetes. So it's really important to promote the optimization of reducing alcohol and tightly controlling our other cardiovascular risk factors. So what are some practical management strategies that I use in my patients that consume significant alcohol? I work in Las Vegas, right? So alcohol is everywhere. I do encourage patients to get structured support. Using AA, getting a mentor are great, resources that they can use for ongoing care. When patients bring their family members to clinic, I really encourage them to get as much involved too. I wish that I could just prescribe to avoid the people that promote us to drink, right? But sometimes we can't just get rid of our loved ones or family members that make life hard. So I try to encourage them to meet friends that are also on a path to recovery and surround yourself with people that will promote you to be a better you. And I think ultimately that's what they need to get out of their toxic environments sometimes, but it is hard, right? And it's not going to happen overnight. So we do have to know that when we're working with these patients that there's going to be ups and downs, and we're here for the long haul. Okay. I'm also a big promoter of medical assisted therapy. I like to promote addiction medicine. Maybe a patient may benefit from naltrexone, Camprol, or Antabuse, but they need that referral to really get there and get those options. Studies show that in inpatient settings, these patients are frequently being seen in the ER for intoxication and withdrawal management, but less than 5% actually get referrals or recommended medical therapy for their addiction. So I really think we have a lot of work to do in that area. I also think that the GLP-1s may actually give us some more opportunity to, one, help with metabolic dysfunction, reducing blood sugar, lowering their weight, and also helping with cravings. But I know we need more literature on that, but I do think it will be promising to offer to patients. So lastly, how do we use our non-invasive tests accurately in the setting of alcohol? We know that alcohol will increase our transaminases and will skew our serologic testing, will also skew our reliability of our elastography. Ideally, we want patients to be avoiding alcohol for several weeks before doing so we can actually get a good baseline. But we often can't do that, right? But it can also be used as a tool to show patients just how dramatic the alcohol is affecting their numbers, right? So if you get a patient that's really interested in trying to cut back or quit, and you repeat your FibroScan or other non-invasive test in, maybe 3 months and show them just how much improvement has been made, it may help encourage them because now they have something tangible that they can see, an actual data set, a point that in time that shows improvement and may help them stay on the right path. So I hope you enjoyed this talk on how we manage alcohol and MASLD and some good tips on how to encourage patients to reduce their risk factors and really understand the synergistic effect of their metabolic function with their alcohol consumption. And I'm here if you have any questions or need any other advice. Thank you.